I am Alex Dolezal, and I'm the Digital Health and Quality Improvement Team Leader at Central and Eastern Sydney PHN. Our speaker today is Adrian Power. Adrian is the collaboration lead for Lumos with the New South Wales Ministry of Health. Adrian is driven by working with people to improve health and business outcomes using data. Adrian has worked with various health organizations to leverage data, including government health departments, primary health networks, general practices, mental health and disability service providers. Adrian has qualification in health science and data science. Please welcome Adrian.
Thanks, Alex, and hi, everyone. Welcome to the session today, where we'll be talking about Lumos and in particular, a focus on the most recent general practice reports that have been developed for it. So if you're new to Lumos, this will be a good session to sort of get an overview and an understanding of what you could expect from participating as a general practice. And if you are participating in Lumos, you'll get a good sense of what are in the most current practice reports that you would have received for participating in the program. It's an open session, so please feel free to ask questions and I'll try to cover those as we go. And if not, there'll be time at the end for a little bit more discussion. So without further ado, I'll stop sharing my video and start the presentation. So we might just start with a little bit about what is Lumos, particularly for those that are new to the program. So we know there's opportunities to improve patient experience and outcomes across the healthcare continuum. But to do that better, we need to understand what patients need. And without a system view that incorporates the patient journey across primary and acute care settings, we're essentially managing in the dark. So Lumos is a pioneering initiative that sheds light on that patient journey across the different healthcare settings by linking de-identified data between primary and acute care under ethical approval. So what is data linkage? Essentially, it's joining up the dots of the services a patient might have accessed. So one patient might have gone to your general practice, been admitted to hospital, visited an emergency department, and it's a matter of connecting the dots to see the services that patient accessed and when, but in a de-identified way. And some of the things that you could do with that information at a higher level is to look at things like when patients, say for example, visit a GP within a week following their discharge, they're less likely to be rehospitalized within the following 5 to 12 weeks. So that linkage is very important information and unique information. And what we'll be focusing on today is what is provided to you as a general practice about your patients. So over the next couple of years, we're hoping that Lumos will generate insights on up to about half the population of New South Wales. And we're currently doing data linkages twice a year in April and October. So it's an unparalleled opportunity that we have to inform and underpin the transformation of care in New South Wales. We currently have, this is a little bit old now, but 420 general practices participating, which is about 15% of the state. Participation is voluntary and it's in partnership with PHNs. So please reach out to Alex and the team at Central Eastern Sydney if you're interested in participating in Lumos. And what do you get for participating? Well, you'll receive a personalized report, which gives you information about the services your patients have accessed across the system, which has never been available to general practices before. So it's very new and very exciting information. So I mentioned in the last slide that currently 15% of practices are participating. We did a study to determine how representative the Lumos data is at a population level for the state. And with only 5% of general practices, we found that the Lumos data was representative of the population. And there's a link there to the article or the paper in the Integrated Healthcare Journal below if you're interested to read more about that. So what's in Lumos and what's included? So essentially, to the records of your patients that have visited your practice from 2010 onwards, we're linking New South Wales health data sets like hospital admissions, emergency department presentations, whether someone's in an integrated care program, whether they've died from the Registry of Births, Deaths and Marriages, whether they've had an ambulance service, a community or an outpatient service, or recorded in the Central Cancer Registry or mental health ambulatory settings. So this is all de-identified information, and it's a really broad cross-section of the services that your patients might have accessed in the health system. And what can we do with this information? It's really for the management, planning, evaluation, and funding of health services. And one of those things is the general practice reports, which is the topic of the session. So we'll just transition into that now. And again, if you're not currently participating in Lumos, you'll get a good sense of what you'll benefit from doing so. And if you are participating in Lumos and have your reports in front of you, you'll be able to follow along and learn a little bit more about what's in them. And there is a sample report available for those that aren't yet participating but want to see what you'll actually get in a bit more detail. We're just going to touch on some of the highlights of the report. We won't be going through the whole thing in detail. So these reports have been based on extensive GP feedback over several years because we want to make them as meaningful and relevant to general practices as possible. And again, it's information that's available for the very first time, and it's continually evolving. So what's new in this latest version of the reports, we've added some considerations for interpreting the information. And again, that's been based on feedback we've received from practices and PHNs. We have some new charts that we've included. We've added some key insights. And we have a condition in focus that changes with each report. Last one was diabetes. This one is mental health. So just a little bit of terminology so things make sense as we go through some of the following slides. We refer to this practice in the reports, and that's essentially all the patients from your practice who visited during the reporting period, which we'll get to in a minute. We refer to this PHN, which is all the patients from the practices participating in Lumos within your PHN boundaries, so Central Eastern Sydney PHN in this case, and all PHNs, which is all the participating practices from the state. And the sample report is a random sample. It doesn't represent an individual practice. That's what we're putting that out. And throughout the report, we'll be looking at averages, and they're available to provide context with your practice, your PHN, and the state, which is really where a lot of the value of these reports lie, in having that broader understanding of how things compare within regions and across regions. And we'll come back to that as well. The reporting period for these October 2020 reports were actually for the financial year of 2019-2020, so 12 months. And it's worth pointing out that in this report, I actually don't think private hospital data is included. It's just public hospital data, but I could be wrong in that. I would need to come back on that. But the report covers the last 12 months because that is probably the most relevant period of service utilization to you as a general practice and in general, and covers, in this report, it covers a little bit of the COVID pre and post period as well. So it's a little bit of an unusual time in that regard. So in terms of the practice context. We recognize that every practice is different. So it's really important that when you, as a practice, interpret your report, that you're the best, you're the expert in terms of interpreting your report. Essentially, you know your patients best and the context of your practice in your region. And so it's not to say that, you know, one practice is doing better than another practice. It's simply to provide a comparison so that you can understand the context of your practice and your patients. So, you know, one practice might visit residential aged care facilities, in which case you might have a more substantial older population, which might lead to higher numbers of hospitalizations. Or you might be in a regional area, which could have considerations around access to services. You might specialize in women's health or mental health, or you might be a solo GP or in a large multidisciplinary practice. So essentially, when you interpret the reports, again, it's up to you and your knowledge and expertise of your own population. But one of the things that we provide to help sort of provide context and help you interpret your report is provide some demographic information. So that includes age and sex. And so if you look at the chart on the right-hand side, you'll see the bars in yellow represent your practice. And the little numbers on the right-hand side indicate the percentage that the yellow bar corresponds to. So if you look at the 85 plus age group for females, you'll see that 2.4% of your female patients are in that age group. And then you can compare and contrast that to the PHN and the state. Similarly, on the left-hand side of this slide, you'll see we've provided some information on the socioeconomic status of your patients in 5 different categories from most disadvantaged to most advantaged, which again can really help you understand some of that context. So some of the information that we provide is aggregated to a pretty high level. So for example, for the patients that visited your practice within that reporting period, what proportion of them also presented to the emergency department or were hospitalized or had an outpatient service or accessed an ambulance service compared to the PHN and the state. Again, which can be really helpful for understanding what services that your patients are accessing and really is information that hasn't been available before. So you might find that quite interesting and useful. And there you go. There's a reminder that the private hospital admissions have been excluded from this particular report. So that's a little bit of information on services your patients have accessed. We also provide some information diving a little bit deeper into the combination of services that your patients have accessed. So what this chart is showing, this Venn diagram, is the intersection or the overlap rather between patients who have been to, for the patients that have been to your practice in the last 12 months, how many went to hospital and also went to the emergency department. And in which case on this slide, it would be that little portion of the chart that sits between the red circle and the gray circle and is indicated with the number 10 for 10 patients. So that would say that 10 patients went to hospital and ED. For outpatient services, the blue circle, you'd see that 221 patients had an outpatient service in that visit. So this will let you see sort of the combination of services patients have accessed, which again can be very useful to understanding where your patients are going when they leave your practice or outside of your practice rather. And I've just seen a question come up in the discussion, so I'll just pause and address that. So the question is, will antenatal or maternity information be available as part of Lumos reporting data collection under the condition in focus options? That's an excellent question. I would say, first of all, Lumos isn't a complete collection of all the information that's available either in your general practice or in the New South Wales Health datasets. It is a little bit limited, particularly with general practices. It's limited to chronic diseases in terms of the diagnosis. And there's no information in terms of referrals from the general practice or to the general practice. So in terms of antenatal or maternity information, that currently wouldn't be included in the reporting, but it is something that I could certainly see would be valuable, and for us to maybe consider including that in the future if it's possible. But excellent question. Any other questions from the audience before we continue? Okay, we'll move on. So then we give some information around the frequency of general practice encounters. Well, basically, how often do your patients visit you is what this information is providing. And this can be quite helpful in terms of interpreting charts that are available later on in the report, but it's also quite interesting in its own regard. So it breaks down the proportion of your patients that visited you between 1 to 5 times in the last 12 months, or otherwise 6 or more times. And again, by region and state. So this can be quite helpful. And you'll notice the text that's provided above the chart gives you some additional information and statistics that aren't in the chart that can also be quite interesting as well. So this chart takes that a little bit further, and what it shows for both emergency department presentations and hospital admissions is the proportion of your patients that presented to either of those services, broken down by age group and the number of times they visited you in the last 12 months. And this chart is based on feedback from GPs in the earlier sort of versions of reports that wanted to know a little bit more about, well, we don't just want to know what proportion of my patients visited the emergency department, that's great, but we want to know who is visiting the emergency department. You know, how old are they, and are they patients that visit me often or not? And so this is the result of incorporating that GP feedback. So again, it's not going to necessarily be interesting for every practice, but for some practices, that information will be quite useful. So following on from the ED presentation information, we dive a little bit deeper into that as well in this chart. So what this is showing is for the most recent emergency department presentation for your patients, it looks at 2 time periods. On the left-hand side of the chart, it looks at before the ED presentation, and on the right-hand side of the chart, it looks at after the ED presentation. And what it's saying is what proportion of patients visited my practice either before or after their most recent ED presentation. So the way you would interpret this is on the top line, the yellow line representing the practice. On the left-hand side, you'd see that 16.3% of patients visited the practice within 0 to 2 days before their most recent ED presentation. And on the other side of the chart, 15.2% visited 1 to 2 days after the most recent ED presentation. And one of the ways in which, or some of the ways in which this information might be helpful or interesting or relevant to you, a good example is in the chart below, which is just some made up data. But what it's showing is in that red circled section of the 3 to 7 days post discharge from ED, 6 or just about 7% of patients visited the practice after discharge. If you compare that to the PHN or all PHNs, it's about half compared to those. And then if you look at the next time period to the right, which is 8 to 14 days, 19% of those patients, or almost 20%, visited within 8 to 14 days. And it's a little bit less for the PHN and all PHNs. So it basically means that patients aren't getting to this practice as quickly post-discharge as for other practices in the region. And that could be for all sorts of different reasons. And it's not necessarily good or bad. It's just presenting the information as it is. And then it's up to you as a practice to interpret that. So some of the reasons could be that, not necessarily for Central Eastern Sydney, but for another PHN, it might be that you're in a regional or a rural area that has inherent challenges around access to services. It could be that there's opportunities to help facilitate a follow-up visit post-discharge. And so in which case does the hospital or the emergency department have your up-to-date contact details of your practice? Do you receive timely discharge summaries? Is there an opportunity if, let's just say, your practice capacity is very low, you're a very busy practice, it's tough for patients to get in quickly. Is there an opportunity to provide telehealth consults to facilitate that community of care or continuity of care for patients that aren't able to visit immediately after discharge? Or could you work together on pathways with other local initiatives, or could you work with your PHN? There's all sorts of different things you could do with that information. And again, it's not always going to be relevant, but sometimes it will be. And when it is, it's great having this comparison to the PHN in the States, so you can really see that in context. So again, I'll just pause for a few seconds for questions, and then we'll continue on. So comment from Martina: telehealth still takes time, and it's not a solution to practice with low availability. Yes, that's true. That's a very good point. I suppose it could be helpful, not necessarily in the Central Eastern Sydney region, but maybe for other areas where there's accessibility issues that could potentially help. But I would agree, if there's capacity issues, it might not be a solution. Totally agree with you. Okay, so moving on to some more charts that are in the report. So then we take a dive into hospitalizations. So giving a bit of information and context around why your patients were admitted to hospital. And again, the focus is on chronic disease. So we're not in the reports providing information on all the reasons for hospitalization. It's really a narrow focus, again, on chronic disease. So what this chart is looking at and how you would interpret it is, what is the main diagnosis that someone received when they were admitted to a hospital stay, and the primary reason they were hospitalized. This is what this chart is showing. There's also a chart under this one on the same page, which provides information on the other reasons that a patient, other diagnoses for that hospitalization for that patient. So while your main diagnosis could be cardiovascular disease, related to cardiovascular disease, there might also be a diagnosis, say, for example, for diabetes or something else, which would be reflected in the subsequent chart. But in terms of this example, we're just looking at the primary diagnosis, and you'll see that your practice is represented as a yellow dot, and you can see the proportion of patients at the bottom of the chart. So this practice had about 8.5% of patients in the last 12 months that were hospitalized with the primary reason being cardiovascular disease. that visited your practice within the last 12 months. And then the PHN represented with the little green cross and the blue bar representing all PHNs. So again, it just gives you that context between the region. So how this information might be useful, in the example below, this practice had a higher proportion of patients with cardiovascular disease compared to the region. So why could that be? Maybe they have an older practice demographic. They see a lot more, say for example, patients at residential aged care facilities, in which case that is something you would expect to see. Or it might highlight opportunities to look at chronic disease coding at your practice. So an example of how one practice used this information was by noticing that their proportion of patients that were flagged with chronic kidney disease seemed to be less than the area. And so they were able to go into their clinical audit software, review patients that were potentially flagged with CKD, and then follow that up accordingly. And that was very helpful information. Without that context, they might not have identified that there was an opportunity to review that clinical coding. So that's just one example of how that information might be helpful, but there could be particular diseases of burden or interest in your region that this could prompt you to consider running disease-specific clinics or screening or anything that might be appropriate, again, based on your knowledge of your patients and interpretation of the information. So again, so sorry, there's a question here. Can you clarify the primary reason for presenting is not what's being charted here? That is, a heart failure patient with a broken foot would show up on this chart or not? That's a great question. So if someone had a broken foot as the primary reason they were hospitalized, it wouldn't show up on this particular chart as the main diagnosis. But if they also had heart failure, and that was relevant during the hospital stay, then that would be charted in the secondary diagnosis. So hopefully that makes sense and answers your question. Thank you. Okay, great. So condition in focus. This time we have a mental health condition in focus. And I don't have examples of what's included in this chart in this slide deck, but there's some good information around prevalence, some mental health specific MBS items, and service utilization across different health settings. So again, can be quite helpful, particularly if your practice has a high proportion of patients with that have been flagged as having mental health conditions. We're hoping in the next condition of focus to potentially do either a respiratory focus, so COPD and maybe asthma as well, or a cardiovascular condition in focus. So keen to hear your feedback on the usefulness of this information for you. In fact, in the surveys, we've provided a link for practices to give us feedback, de-identified, around the reports and what's good and what's bad. So we're always keen to hear your feedback around what could be useful to you, and to keep continually improving these reports so that they're as valuable for you as possible. And I think this is the last set of slides. So just one more example of what's in the report. Again, it's almost 30 pages, so there's a lot of information there, and we're just touching on some examples that are available. Is some information around when your patients visit the emergency department. And so there's just a comment here. Respiratory would be great given the current climate and the October reporting coinciding with seasonal respiratory issues. Yes, totally agree. Thanks for that feedback. Couldn't agree more. So this ED chart, ED presentation chart, what it tells you is when someone visits the emergency department, they're triaged and they're given a sort of, they're assigned a category in terms of how urgent their presentation is. So if it's very urgent, they're given a triage category of 1, which is resuscitation, or otherwise emergency and urgent. And if it's less urgent, semi-urgent or non-urgent, they're given a triage category of 4 or 5. So if you look at this chart, the blue line is the number of ED presentations by hour of the day for the really urgent categories, and the pink line or the salmon line or whatever color that is for the non-urgent categories. And how this might be helpful is not always, but sometimes a triage category 4 and 5 presentation could be certainly something that could be seen in a general practice. It's not always possible for, that's not always true, I should say. But how this might be helpful is if you see on the chart for your practice, maybe a particular spike of triage category 4 and 5 presentations, say right at the start of the day or right at the end of the day, or maybe you close in the middle of the day for lunch, it could indicate that there's an opportunity to either extend your service hours or at least review your service hours, because potentially patients are going to the ED if they're not able to access your services. Is just one way that you could interpret this information. We've also, for the first time in this report, provided that breakdown by the day of the week, which again could be quite useful to you. So just some ideas that practices have given us, PHNs have given us over the years of how this information has been helpful to them, that we've provided in the reports, is looking at the number of ED presentations per hour of the day. So are the numbers high enough to consider expanding your services? So for example, if you saw a dramatic spike of activity with a large number of presentations at, say just after you close, if it's big enough, it might really warrant looking into that. Maybe there are some after hours services you could make available, or commission or provision. Is there an opportunity to bring on another clinician, either a GP or a practice nurse? So I know one practice was looking at implementing a nurse-led clinic first thing in the morning to help triage patients coming into the practice at that really busy time, so the GPs could see them more efficiently. And another idea is online booking systems in the context of, if your patients knew you were available, perhaps that might help them make the decision to go to the practice rather than the ED. But again, it's really something that only you as the practice can interpret based on your particular patients, your region, etc. And there's a question here: is there also scope for New South Wales Health to triage over the phone for ED presentations that do not come by ambulance? So self-referred or walk-ins that could give support over the phone just before people walk in. Look, that's a great question that I'm not qualified to answer, but certainly great feedback and something that I would pass on appropriately internally. I don't know the answer to that question, but it's really great that you've asked it. So I'm just going to take a copy of that and forward it on after the session. It's a great suggestion. Okay, so that brings us to the end of the presentation. So we've got a good 5 or 10 minutes left for any other questions or comments. I hope you found that helpful and interesting. For the practices that are currently participating, I hope that helps you interpret and understand the information that's been provided in your report that you would have received recently. And if you're brand new and considering participating in Lumos, I hope this gives you a sense of what you can expect and the value of participating. And again, encourage you to reach out to Alex and the team at Central Eastern Sydney to participate. They'll be able to give you all the information you need and help you with that.
Okay, Adrian, thank you for the most informative presentation. Do we have any more questions from any of the attendees, please? And feel free to paste them into the chat box. Well, Adrian, I would have one question, and that's what enhancement or new data sets are you planning to implement later in 2021?
Great question, Alex. At this stage, we're looking to potentially include FOBT, so fecal occult blood testing information as part of the data collection. In terms of the reports, at this stage, they're probably going to remain pretty consistent, and there probably won't be too many changes to the data that's being collected from all the different data sets in the near future. But what would be really helpful is for the practices that do get a report to fill out the survey and let us know from your perspective what is interesting to you. So we've tried to strike a really good balance between the length of the report and sort of all the areas for interest. But if there's something that's particularly helpful to you and we don't have it as part of the report, if you let us know, we can look to incorporate that.
Thanks, Adrian. I just remember last time we held this workshop, which was, I believe, in late February, you mentioned you might be looking at some COVID-related data sets as well. Is that going to happen or not?
Yeah, that's a great question, Alex. We were quite a while ago looking at the feasibility of including COVID results from the NSIMS, which is the Notifiable Conditions Information Management Database. And that's we're not going ahead with that actually, probably because the amount of information available is quite limited. But what we do have in regards to COVID is around telehealth and telehealth adoption as it's related to service provision, which I think is going to be interesting in future data sets where we can look at, I suppose, maybe continuity of care, or just even the way that service provision changed over the pre and post COVID period, telehealth or otherwise. So I think that's probably going to be the most useful and relevant information which we have. But in terms of COVID testing and whether someone had a positive or a negative test, we won't be at least anytime soon including that information.
Thanks, Adrian. I think that's still going to be most valuable to see those telehealth